Good evening, Dr. Sant. Shall we start? Now, Hemant, you can unmute, please.
Good evening, sir.
Good evening.
Yeah,
I
sure.
think if Dr. Viresh can share the slides and we can start if you are okay.
Okay.
I talked to Dr. Sudhir. He said he might join from US. He's interested. No? So
Good for him. Yeah.
said I might join. I told
Yes.
Dr. Sinha, and of course I told Dr. Rodgi also, but I don't think they will join.
Uh-huh.
Sinha might join after some time because he's out somewhere.
Oh,
Okay. So I think we
yes.
can start now. Dr. Viresh, you can, good evening to you. Unmute yourself and share your screen.
Good evening, sir.
Are you able to share?
Yes, sir.
You start your video also. Let us see you.
Hmm. He will say, you show your face first.
Yeah, I'm ready.
So put it on the slideshow.
Yeah.
Is it okay, sir? I think it's visible and audible.
Yeah, of course.
Yeah.
Yes, I think it's start. Did you unmute yourself?
No, sir. Shall I start?
You can start now.
Okay. Good evening to all. I'm presenting a case, Mr. SB, who is a 63-year-old male, right-handed, studied till 12th standard, and was working in the Indian Army as a vehicle controller. He retired 20 years ago, and then he was working as a driver on transport vehicles and stopped working since last 5 years. Informant being his son and his wife, both are reliables, presented with chief complaints of visual hallucination since 3 years, forgetfulness since 3 years, and a change in behavior since 2 years. I'll continue, sir.
Yeah,
Right.
what's a change in behavior? Yes.
Before starting history of present illness, I would like to mention some daily routines of a patient before the illness was started. Patient was all right 3 years ago, doing his activity of daily living. His pre-morbid daily lifestyle was healthy. Wake up around 5:30 a.m. He used to have a morning walk with his wife or his friends. And after morning walk, he used to clean his house, courtyard, and home because he likes to clean his courtyard and some gardening, and then went to nearby places with social activity and gathering with his friends daytime, and then during in night at around 10 p.m. he slept. He has significant interest in politics and was a very interactive person. Family noticed some altered behavior 3 years ago in such way that he was talking with imaginary persons, asking them to come inside a home, take a tea, asking his wife to make a tea for them. These imaginary persons were known to him and his family also, and these imaginary persons were alive. Some episodes like asking his wife to make a dinner for a brother who was not there, and after a 15 20 days, some episode like informing his wife that his mother came at bus stand and he had to go to pick up her. Actually, her mother was never come there. There's
But they were alive,
sir,
both of them.
all are alive. Both are them alive.
Alive. Yeah. Okay.
Yes, his father and his mother both are alive.
Hmm.
Uh, Nowadays, previously, these episodes were infrequent. Now the situation become worsen, and nowadays these behaviors are almost daily. Uh, Meanwhile, a family noticed that he was forgetting things easily, like where he placed objects like keys or the remote of the TV where they were placed. and also used to forgot whether he had breakfast or not, and repeatedly asking for the same. Also, he is not remembering the relatives who are the recently visited them. But patient denied that he had any illness like forgetting or uh, talking with imaginary persons, because his wife and his son used to told him that some change in his behavior, but he denying that. But he could remember his past things, such that where he was working, then his names of some his officers, and share some army experience. He also likes to share his army experience where he was posted that uh, during same period, wife noticed the episodes of some abnormal, irrelevant talking during the sleep, moving his hands in such way that as he was awake and working something, or talking with some things. But my wife didn't understand his language, and some incidents of sleepwalking also there. And so family noticed that there is a change in sleep pattern, such that he goes to bed easily. Duration of night sleep also increases, and daytime sleep duration also increases than the previous. Uh, but meanwhile, his wife and his son was working in Pune, and the patient was residing at Kolhapur. When son visited his home, then he noticed every time he noticed some change in his symptoms intensity and frequency, and then some patterns of his daytime sleepiness, and talking with imaginary persons. Uh, then progressively, family noticed that previously he was a very interactive person, used to interact with people a lot, and had a hobby of cleaning home, courtyard, and gardening, but gradually become less interactive. He started sitting alone, stopped reading newspapers, also reduces the uh, gathering with his friends, and reduces his interest in also in gardening also. Nowadays, he does not pay attention to what his family being asked to him. Family have to repeatedly ask similar questions again and again. Uh, and also in progressively his mood, there are the mood swings. He becomes angry on the little things previously which he was not doing. Gradually, and also there is some change in his appearance, some change in his working, like he gradually stopped keeping his clothes and other objects in organized manner. Previously, he used to do all his activity in clean and neat and organized matters. But there is no any history of social inappropriate behavior, or no history of any events of undressing or dressing at inappropriate places. Family also noticed that there is an increase in frequency of urination. Previously, he had a sensation and rushed toward the bathroom and asked family about the way, but had episodes of incontinence also. Progressively, this is worsens, and family noticed that he is passing the urine in the clothes also. Uh, Previously, he becomes the guilty or embarrassment about the passing the urine in clothes. But nowadays, there is family notice that there is no guilt in his expression after the passing the urine in the clothes. Uh, uh, and also, family noticed that it change in his eating pattern. Like previously, he had a specific quantity of chapati and rice for his routine diet. Nowadays, he is not denying if the family offers more chapati than his usual limits. But there is no history of demanding any specific types of the foods. But while eating nowadays, he is mixing both sabjis or rice inappropriately, which was not previously, and it was noticeable by the family. Uh, Nowadays, there were some episodes where he was not recognizing his grandsons, and also sometimes he is not recognizing his wives. Also, there are two important episodes which are noticeable to his family. That one day he was asking his wife about where is his wife, and in the next time he is asking his wife that. Where are your children? How are they? And thinking that her wife is not her wife, but she is a maid of there. Uh, but during this episode, he answering coherently, and there is no any involuntary hand movements or any oral movements also. Uh, Progressively, he was not remembering ways to the home, used to get easily lost. When he went to shop, then family noticed that episodes of there are they did not returning back. Then family searching for him. Then he found in opposite colony. And this the difficulty in remembering ways to home is progresses in last 1 year. Nowadays, he also forgetting the ways inside the home. Where is the bathroom? Where is the kitchen? Uh, so difficulty in finding the ways in inside home also. Uh, there is a change in gait pattern which was observed by the son that his speed becomes slow, takes more time to reach places than before, and also notice that there is a difficulty while initiating walk. Steps become shorter with little dragging, mainly left foot, and then increases the speed of walking. While turning, he requires multiple steps, and overall during walking, he looks like he bending forward while walking. Uh, Progressively, he has a difficulty in wearing the shirts properly in such way that nowadays he cannot identify the sleeves of the shirts. uh, when you put his both hands in one sleeve of the try to put his both hand in one sleeve, or the try to put both legs in one sleeve of the pant. Uh, Few times he wears the shirt in a wrong way, that is the back to front order was missing. Uh, and also, there is a difficulty in wearing chappals in such way that instead of putting whole foot in chappal, intermittently he used to put only one toes, and also difficulty in navigating it. And there are some incidents that he was walking with a single chappal alone. But once where the chappal, there was no slippage of chappal. Uh, and he also had a progressive to difficulty in handling money. My family noticed while doing a grocery shopping that he was unable to calculate the returning amount of money from shopkeeper, but he bought a correct object which were listed on the paper, and that paper was given by a family member to brought that objects. There is difficulty in calculating of the remaining amount mainly. So I'll continue, sir.
Yeah. You finished the history, yeah? At least.
Uh, but
Just go back one slide. Difficult. Okay.
uh, there is no history of any double vision, any facial asymmetry, difficulty in chewing, swallowing. There is no history of change in voice. There was no history of inappropriate behavior like a laughing or the crying in inappropriate places and inappropriate situations. No history of tremors, no history of involuntary jerky movements. There is no history of seizures or loss of consciousness, and no history of dizziness on sudden standing from the lying down position. There is no history of any significant history of drug and the toxin exposure, denied alcoholism. and no history of fever, weight loss, abnormal sweating, sorry, slowing, and no past history of stroke, any head injury. Personal history has a mixed diet and no similar illness in the past.
Okay. So let's analyze the history. The main issue is visual hallucinations, then the memory issues, and change in the behavior. That's what done over a course of last 3 years.
Yes.
Any questions from anybody who wants to ask? Any points he missed in bringing out the history? You can unmute and answer.
Family history?
No significant family history, and his patients, both father and mother, are alive, and there is no such history. But as age-related father, there is history of forgetfulness, but not significant as per family.
Mm-hmm.
Okay. So from every Soumya signaled weight loss, alcohol history.
No history, sir. No
Yeah,
history of weight
that's
loss, alcohol, or any drug intoxication.
Okay.
uh,
So in the course of history, you have brought out so many points. Diurnal variation, somebody asking. Vishweshwar.
yeah, that he said, he mentioned.
Is there diurnal variation?
Not a diurnal variation,
Hmm.
but as per son, because son is working in Pune and patient is at hometown Kolhapur, but every time son visited homes,
Hmm.
he noticed some change in his symptoms, in frequency and
But that is not
intensity.
diurnal. Diurnal
It is
means
not a
morning
diurnal
versus
variation. No, it's
diurnal
not
means
such.
morning, evening, sundowning
Uh,
effect. You know what
Uh,
is sundowning effect?
yes,
uh,
yes, sir.
in-
Dementia,
Huh,
cognitive impairment is worsen during evening and night period.
correct. So that is diurnal variation, not
Somebody is asking fluctuation. Is there any fluctuation in his cognition?
Sir, similar that Sun's history, uh,
Hmm.
from that Sun history, I think it's fluctuation because he visited in 10 to 15 days. So there
Okay.
he noticed some changes. So I think there are the
The,
fluctuations.
the changes are gradually worsening, what Sun observed.
Yes.
But
Sir, one history I'm missing actually, sorry.
hmm.
There is a treatment history also.
Hmm.
Meanwhile, he visited local consultation, and
Hmm.
after taking some medication, as
Hmm.
person is improved, but again it worsened. So that improvement is associated with any medications or fluctuation.
I think Dr. Soumya Singhal, what do you mean by fluctuation? Why do you want to? What is the importance you have given to this point?
Because
Man,
mainly
Dr. Soumya will answer. She has asked this, and you have answered already. You can unmute and answer. In fluctuation in this type of setting, how will you? Yes.
Sir, I wanted to ask regarding fluctuation that is there any improvement in between for some days and then again worsening for symptoms? Because that is a feature of this dementia with Lewy bodies.
So you want to know whether there's a fluctuation in the day, in the week, in the month, or fluctuations at all? Punctuated?
uh,
Yes. So one of the things which you wanted to ask. Okay,
the
Virish?
fluctuate, sir, in days or months, I wanted to ask whether for weeks or months, or whether there was some period that patient was better for some days and again then again worsening for some days, sir.
Okay. Dr. Viresh, could you elicit that history?
Uh, yes, sir. That history, as per the son, when he visited home, there are some changes.
No,
Uh,
changes are better or worse. See, every time he visited, the disease has progressed.
yes, but
But
meanwhile, changes improve, sometime worse. Like this.
so that is one issue, which is the visual hallucination. How do you analyze the visual hallucinations, Viresh?
Uh,
So
there's
what type of hallucinations they are
these
called?
are mainly well-formed visual hallucination.
Uh,
Uh,
where all you see hallucinations?
Mainly in dementia, delirium.
Hmm.
Uh, then not well formed, only flashes of light,
Hmm.
like in migraine or also possible.
Anybody
yeah,
else
and
can answer this question?
Which other case condition?
And in psychiatric like schizophrenic, but
Yes,
they are
so-
mainly auditory hallucinations are there.
Okay. Encephalitis, HSV, these are
Yes.
acute conditions. So there's no 3
Yes.
scores that's happening here. One Dr. Soumya is asking whether there is any neuroleptic hypersensitivity. Was he exposed to any psychiatric drugs?
Uh, uh, no, that history was not given.
I say you didn't obtain that history.
Yes.
Okay, then there is another thing which he was talking in imaginary things. No? So
Hmm.
that he was talking to somebody, and how do you explain this?
Uh, Sorry, did not get.
He's not only imagining persons, but he's talking to them also.
Yes.
Uh, Does it happen in the dementia, or is it's a feature of
Hmm.
schizophrenia?
Uh,
The
Maybe
one-
happen in dementia, mainly delirium and
what is the difference between delirium and dementia?
uh, delirium is mainly acute change in cognition.
Cognition, or what is the main defect in delirium?
Uh,
Which
okay.
disturbance happens? Delirium
Yes.
is mainly due to what domain affliction?
It is mainly due to diffuse
Attention, that is Vineet is saying.
attention.
Attention. See,
Oh,
delirium is acute confusional state,
Hmm.
heightened
Confusion.
activity, and attention is not there, flight of ideas, and he'll go on thinking here and there, but he won't answer to you. Okay,
yes.
that is the delirium. And how do you define dementia then?
Uh, Dementia, mainly it is a progressive
Hmm.
worsening in cognition.
That's okay, but you have to tell me whether it's DSM-4 criteria, DSM-5 you are telling, or any other ICD definition. Which definition you are telling? Cognitive decline in more than one domain.
Yes,
Yes.
presence of mainly acquired impairment, mainly in memory and with more than one cognitive domain.
What are the 5 domains which you look at?
Executive function,
Hmm.
uh, then language,
Hmm.
then praxis,
Hmm.
then gnosis,
Hmm.
and visual spatial orient
Visual spatial dysfunction. Okay,
dysfunction. Yes.
right. So in this, in your case, how is apraxia or praxis indicated in this?
Uh,
Aphasia, apraxia, agnosia, that's correct. Executive control function. And in drugs also cause hallucinations. How did you elicit the history of apraxia? What are the points that suggest apraxia in your case history? Anybody?
You have mentioned them in your history. So which
yes.
Yeah.
of these denote apraxia? Which of your
Main,
history points?
one is a dressing.
Dressing apraxia, yes.
Dressing. And secondly,
Secondly, that wearing the chappal, I think,
Hmm.
wearing the
because
chappals.
instead of putting whole foot in chappal, in put to only toes, so it may be part of apraxia or inattention.
Okay, what are the features of executive control dysfunction in this case? Any
Uh,
points which you can suggest? What is executive control function and where is it localized?
Executive functions mainly in frontal lobe, mainly dorsolateral,
Dorsolateral.
prefrontal.
Okay. So,
Uh,
so what are the characteristics of executive function disturbances? What are
uh,
affected?
Mainly planning, impairment
Breathing.
in planning,
Uh,
monitoring,
mm,
then impairment in judgment.
Execution, planning, and execute also, no? Any
Yes, sir.
history which you have
Thank you.
taken? Whether
That
he can
history,
go out and come back. See, that's also, if he has to go to shop, he has to plan how to, which route he has to go, how he has to go and come back.
yes, he used to go to outside, but there is history of forgetting in the ways mainly.
Is it visuospatial dysfunction or is it? So can you give any history suggestive of executive control? And what are the domains in this patient affected in your opinion?
Uh,
Memory,
Memory,
yes.
then visuospatial,
Visuospatial,
then praxis,
praxis.
and also executive function.
That I'm not very clear what you have pointed out.
Previously, he used to place his object correctly in organized manner.
Okay,
Nowadays, that history.
okay. You could remember. So let's address a memory here. What type of memory disturbance you noticed?
Mainly recent episodic memory.
What is
Remit,
episodic memory?
uh, uh, it is about the uh, episodes.
Hmm? What is episodic memory? What is semantic memory?
Semantic memory is mainly general knowledge, and
Okay.
episodic memories are mainly the events in his life.
Episodic memory is time traveler. You
Yes,
go
sir.
back in time. What
Yes,
time?
how is
See, so it is time locked. So it can be recent episodic memory, remote episodic memory. There is a time connotation in that.
yes.
And autobiographical context, episodic is episodic. Episode means you have to tell time. So how will you elicit episodic memory history?
Uh, about what he eat in breakfast or
Yeah.
in dinner,
Mm.
then any relatives recently visited his places or any places where he visited.
So can you tell what are the various parts of memory which you should know?
Uh, Parts of memory.
Is there can you come stages of memory?
There are mainly four stages of memory:
Uh,
registration, then encoding,
mm.
then consolidation and storage, and then retrieval.
Great travel, very nice. So these are the same. Which part is affected in this case?
Uh, Mainly uh, recent memory, so mainly encoding and registration, and encoding and retrieval.
Retrieval, but he's remembering the remote things only. No? Is well, no.
Yes, sir. For remote memory,
Is so remote memory is stored where?
Uh, remote memory are mainly stored in association cortical area. If it is in language
Mm.
form, then it is language association area. If it visual, then visual association
Mm.
uh, area. If auditory, in auditory association area. Mainly in neocortical region are the remote memory are
For
concentrated.
retrieval of memory, which part is important, which is not important?
For retrieval of memory,
Uh,
prefrontal cortex is important.
Very good, very good. So, has got any hippocampus formation has got any role in that?
Uh, Hippocampus mainly it is in mainly involved in encoding the memory and also mainly in episodic and short-term memory.
Okay, so remote memory for the retrieval of that you don't require hippocampus. That's a point
Hippo
I wanted to
Yes,
convey.
for
So you don't
hippocampus remote
require.
memory. Yes.
So what type of memory disturbance? You said episodic memory. Whatever learning disturbance happens in hippocampal disorders?
Because in hippocampal memory, there is difficult impaired in encoding, so anterograde amnesia happens, and due to this, new learning impairment is there.
Anterograde learning defect. Right. So can you give some examples of semantic memory?
Uh, Semantic.
How will you ask for semantic memory? So that's correct, but facts, events, marriage date is again time locked, but it's a fact. So how will you set sequential memory, categorical semantic memory? How will you test? You have to tell, no? You have to elicit those facts. You're correct, but bedside. Somebody
About
said name of animals. You agree with that? What is name of animals? I just want. It's a list generation.
yes, ma'am.
Categorical semantic. Okay. So all animals, there are two. You can tell number of animals that can be in. That's another type of test. So you can ask the week, days, the months in serial order, right? Various facts, fruits, animals, categories. Okay. Very nice. So where is semantic memory located? Where is it stored? Most of the semantic memory is stored where?
Uh, Mainly cortex.
Which
No.
part of the cortex? You know what is defect? What type of aphasias are there? Primary progressive aphasias?
There
In
are
that,
mainly three type of primary progressive aphasia.
three are there: non-fluent, then
Non-fluent, then
correct.
semantic variant and logopenic
So
variant.
where is semantic variant aphasia dysfunction is due to which part of the brain?
Mainly temporal parietal cortex.
Antetemporal and
Anterior.
semantics. That's where the basifrontal antetemporal region is then called anterior heteromodal association area, where semantic memory is mostly located and disturbed frequently in frontotemporal dementia. Whereas episodic memory disturbance are more common in Alzheimer's disease.
Yes.
What are the primary dementias? Can you name all the primary dementias which you know?
Alzheimer dementia.
Hmm.
Uh, and then from synucleopathy involving frontotemporal
Mhm.
uh, dementia,
Mhm.
uh, then Lewy body dementia,
Very good.
and also Parkinson's disease dementia.
So, there is a difference between Parkinson's disease dementia and other dementias. So that comes to us. There are two things here. What is cortical dementia? What is subcortical dementia?
Yes, subcortical dementia, mainly there is also involvement of frontal subcortical circuits.
Okay.
Uh,
How,
uh,
how does the patients present? That's important, no?
uh, with Parkinsonian features,
Dementia we're talking, not motor disturbance.
mainly impaired memory and which are improved after the giving clues.
The other characteristics of subcortical dementia. Improving with cues is correct. So historically, you have taken some point. Cueing, did you say that point in your history? Psychomotor slowing is very good. There will be slowness in thought process, that is psychomotor slowing. What else? Associated signs. There will
Extrapyramidal,
be extrapyramidal or pyramidal signs.
then
Right?
dystonia maybe.
Any other, but those are absent in cortical dementias. Usually you don't get unless disease is late.
And some change or abnormal speech.
Soumya is saying procedural memory loss. Where is procedural memory located? Dr. Soumya, where do you think procedural memory is located and what's its importance? Procedural memory is different from cerebellar basal ganglia and supplementary motor area,
and cerebellum.
cerebellum. So what is its importance? Is this disturbed in what all conditions procedural memory is disturbed and what all conditions is preserved? What are the conditions where it is preserved?
In
Cycling is preserved.
Alzheimer disease, cortical
Alzheimer's
dementia,
disease, yes.
cortical
Procedural
dementia.
memory can be preserved in Alzheimer's disease, whereas it is in subcortical dementias and Parkinson's disease, it may be affected. So when you go into your history, what are the autonomic nervous system features doing in your history?
No,
How do you account for the urinary frequency and what do you say that? You talked about urinary frequency.
yes.
So how will you analyze that?
Uh, uh, from the history, there are now it progressed to the passing urine in clothes with no guilt behavioral. So likely cortical involvement frontal.
Frontal. So you mean to say, is there loss of insight?
Yes, sir. Insight also lost because family patient denied that he had any illness as a wife or son. Um, uh,
How do you analyze this inability to visualize, recognize persons? You said that, no, unable to recognize.
uh,
Did you say that?
yes, sir. He has an episode of where he was not recognizing his grandson,
Grandson, therefore,
and also
Relative.
asking his actually he is not, but it is not progressive. These are mainly episodes. If progressive, then it's like a prosopagnosia.
the
But
agnosia,
there's
type of agnosia,
yes,
that prosopagnosia. And where is prosopagnosia disturbance located in brain?
fusiform gyrus,
Fusiform gyrus. Which pathway is dorsal pathway from occipital striate or ventral pathway is involved?
ventral, pathway. Mainly what pathway?
That's correct. Somebody is also Patel is saying ventral part, ventral. Yes, it's a
Ventral what?
what pathway?
Yes.
What does where pathway suggest?
Where pathway mainly occipital to parietal.
In this individual, is it disturbed?
There are some visuospatial involvement.
Yes, he is not able to trace.
Way home
He's not.
easily.
Yes, where is disturbed here? So both pathways. So in essence, in your history, you have included all types of areas in the brain,
Yes,
isn't it?
yes.
Occipital where pathway, what pathway, temporal lobe, and some episodic memory disturbances, frontal lobes. So, and any etiology for this?
No any etiology.
Could it be autoimmune encephalitis?
But it's a history, 3 years duration.
Okay. You asked
And
about seizures. What type of seizures you are expecting in this type of situation?
because that episode of not recognizing the vibe, so maybe focal occipital seizures may be there, or also hallucination, visual hallucination, and there are the seizures from the occipital region.
In dementia, what type of seizures we ask for? Myoclonus.
Myoclonus.
Right? Jerky movements, myoclonus. Okay.
So if early in dementia, then you have to ask about myoclonus.
Yes.
Yes.
If it
Yes,
is late stage dementia, then you might get generalized seizures.
there is in negative history. There is no history of involuntary jerky movements.
Yeah. Yes, that's correct. So this is 3 years history. How
So
is
which
the
are the dementia that start with hallucination? Early hallucination. That is your
de-
clue, no? That is your clue
yes,
to the etiology.
dementia with Lewy bodies. Then mainly posterior involvement, dementia like posterior cortical atrophy of
Posterior.
Alzheimer variant.
Osteocortical atrophy occurs at what age?
70.
Slightly early.
Normal Alzheimer is 65, posterior between 55 to 65.
So what are the
Right.
presentations of posterior cortical atrophy? How the patients will present to you?
Mhm. Mainly visuospatial impairment more than the memory impairment.
Okay. Do they have any problem in reading?
Mm,
What is surface dyslexia?
Surface dyslexia.
See, it's not only vision, visual association
Yes, sir.
areas, everything has to be taken into consideration. The posterior heteromodal association area is around angular gyrus on the left side
Yes.
and inferior parietal lobule. It is close to visual area, somatosensory area, auditory area. So, what is surface dyslexia? Anybody? Somebody knows?
Difficulty in word recognition.
Some more clear. So, have to read by letter to understand a word. Okay.
Hmm.
So then they can understand the word. They can't see a word and identify it immediately.
Fine.
So reading difficulties will be there. Okay. Posterior cortical atrophy will be accidents. They'll be because the visual function is disturbed. There may be agnosias.
Yeah.
You have to prevent their accidents when you guide them. Most probably, that's the whole issue is they are not able to read properly. They are not able to judge properly. Whole word recognition is difficult. There is a when a whole sentence is also becoming difficult. Now, whole word is okay, but there are conditions where the whole sentence is difficult to understand. What is that aphasia? Out of the three, logoponic, semantic, and non-fluent. Logopenic.
Logo.
It's not semantic. So logopenic will have this problem of understanding the whole sentence also. Okay. Very nice. So what are the alpha-synucleinopathies which you mentioned in your presentation? What are all the synucleinopathies you know of?
Mainly Parkinson disease, dementia.
Hmm.
Then here dementia with Lewy body,
Hmm.
multiple system atrophy.
Hmm. Frontotemporal dementia, somebody is saying, you agree with it?
And Alzheimer's.
Or behind, there are some others. Pure autonomic failure,
Pure autonomic failure.
REM sleep behavior disorders, right?
Yes.
Parkinson's disease and MSA. So, what is the difference in autonomic nervous system disturbances between MSA and Parkinson's disease? What is the main problem in MSA?
MSA versus Parkinson.
Which part
Mainly
of the autonomic nervous system is involved?
orthostatic hypotension.
Postal drop. But which part of the autonomic nervous system is involved? Postganglionic. It is central. PD is central autonomic nervous system is in MSA. Okay. That's why What is the test you do? Cardiac. What do you do? Any cardiac test which you do to assess the MIBG scan?
Tilt table.
Tilt table and all for autonomic nervous system disturbance,
No.
postal hypotension. But MIG scan will differentiate. What are tauopathies?
Uh, F, FTD, frontotemporal dementia.
Yeah.
Then
PSP.
PSP, CBD.
Mm. What is tau? What is tau?
Tau is a misfolded protein.
Which protein? Microtubular associated protein inside the cell skeleton, right? So tauopathies are differentiated from alpha-synucleinopathies. So can you call them prion diseases?
Prion.
Synucleinopathies, can they be called prion disease?
No.
What is the relationship between gut and PD?
Mainly Parkinson's, starting with gut abnormality. These are early features like constipation.
What is alpha-synuclein and what is the abnormality here? Gut first, brain first. What is alpha-synuclein? Huh? What is abnormality? When do you call alpha-synuclein abnormality? What happens there? Misfolded
Protein.
chain,
Okay.
right? And this will be gradually spreading from gut to which part of the brain first appears?
Dorsal vagal.
See, these Parkinson's disease associated with non-motor manifestations, a lot of them.
Yes.
Yes, sir.
And
They
they
precede.
anticipate. Hemant, you're saying something, sorry.
Yeah, I said they precede the motor
Yeah,
manifestation.
they precede the motor manifestations, and that's why the spread is from brainstem upwards. Okay, so we have discussed this question, I think, at length. I will go to the findings. So you summarize the story and give your diagnosis.
So my patient, 63-year-old male, insidious onset, gradually progressive complaints of mainly visual hallucination with REM sleep disturbance, also in gait disturbance and recent memory impairment with progressive apathy, fluctuations, mainly in attention and visual spatial dysfunction with dressing apraxia and likely cortical bladder.
Cortical bladder or autonomic nervous system disturbance?
Only due to this history that he is not now guilty about incontinence, so
Lack of insight.
lack of insight.
What are the diagnostic criteria for diffuse Lewy body disease? Which criteria you read?
Consensus criteria.
Have you read? Have you
Uh,
read?
Yes, it is with dementia plus mainly fluctuation, Parkinsonism feature, visual hallucination, and REM sleep disorder.
Anybody can quote what criteria are used for diagnosing of DLBD? What are three core features for DLBD?
Fluctuating
Essential criteria,
cognition,
supportive criteria.
core features like fluctuation in cognition, then visual hallucination and Parkinsonism,
Parkinsonism. Okay.
and suggestive or REM sleep behavior,
Hmm.
then neuroleptic hypersensitivity.
Hmm. Are falls associated with this disease? Yes, falls are also important feature of DLBD, autonomic nervous system disturbances, falls. Okay, most of the things which you have done. Okay, so what is your prior diagnosis? One, two, three.
Uh,
Differential diagnosis. See, in any case, you have to generate some differential diagnosis and give. You can't stick to one diagnosis.
yes,
Yes.
mainly first is dementia with Lewy body.
Hmm.
Then due to the visual hallucination, posterior cortical atrophy variant of Alzheimer's disease.
Hmm.
And there is a progressive apathy, then inattention,
Hmm.
and also frontal bladder, and behavioral changes. So frontotemporal, so
Frontotemporal, but you didn't bring out any behavioral disturbances. You said no, that not many behavioral disturbances.
only apathy.
If it's, yeah, it's a negative
Hmm.
symptom.
So frontotemporal dementia is unlikely in this case.
Hmm.
Yes.
It's a because that's predominantly it will be behavioral abnormalities make some. How many types are there in frontotemporal dementia?
Mainly three types: behavioral variant,
Hmm.
uh, then semantic variant, primary progressive aphasia,
Hmm.
and progressive non-fluent aphasia.
Okay. Any other associations?
Uh, Mainly with FTD with motor neuron disease,
Disease,
Hmm.
yes.
with C9orf72 involvement.
And what are the
And
various protein that's affected in this?
C9orf
What else? That damn protein, TDP43,
and
Hmm.
FUS.
FUS, good. Okay, so these are the proteinopathies that are seen in frontotemporal dementia.
Yes.
I think let's have the findings, Dr. Sant.
Yeah.
Okay, go on to the findings.
Uh, on general examination, vitals are normal with pulse regular, BP 130/90 with no postural hypotension. Uh, facial expression is like masked faces. Uh, uh, then motor activity is reduces. External appearance is a clean, wearing not dressing sense was would not untidy dresses.
This PICC is what?
Sorry, sir. It's pyloric stress cyanosis and clubbing.
They are present or absent? तुमने कुछ लिखा नहीं. Okay. Hmm. All right.
Uh, so on higher mental function examination, uh,
Hmm.
uh, here is a chart which was uh,
What is the
attention.
importance of attention testing in cognitive assessment?
Right.
Uh,
Why is it given utmost importance?
if the attention is adequate, then we can test order a domain.
Hmm. In this case,
It's reduce
so whatever things which you are doing, maybe we cannot
impaired.
have reliability on that.
Yes, the TAPE test also impaired.
Okay.
Uh,
What are other
Forward
tests for executive control function? Did you do anything for executive control function?
uh,
Somebody said trial A.
And then
Returns,
trial
returns,
B.
trial A and trial B, returns, trial A and trial B. What is trial B test? How you do that?
Trial B mainly involve the state shifting. There are
Mm.
the numbers and alphabets, and
Mm.
patient has to direct from one number, then corresponding alphabet, then next number. So there
Okay.
is a state
So
shifting.
there's a planning involved and execution involved in that.
Yes.
Okay. So language, what did you test?
Uh, Language, mainly spontaneous speech, and the fluency was normal because he very happy when we asking about his army experience. So he his fluency was normal. Also naming of the object also normal. He can read and follow command. Writing is not possible,
Mhm.
uh, and the repetition of also within not significantly impaired.
Where is writing? What are the areas involved in writing execution? Writing execution, what are all the areas? Writing is very important task which we do. What are the networks involved in writing? All the DM students should know these networks involved in writing. What are the networks involved in the
Executive.
ERNS cortex? What is that? Entorhinal cortex? Soumya, you are saying that? Exner's area. What is that? Tell me, Vinith. Which area is important?
Left tempo.
Left temporal. Yes, correct. The connections between angular gyrus and dorsolateral frontal lobe and frontal lobe and
Yes,
surrounding area of the Broca's area because execution of motor is also involved.
yes.
So it's a long, the writing is a very complex function and reading already we have discussed and repetition. Why repetition is important? The occipitotemporal, that is actually that posterior heteromodal association on the left side and right side around angular gyrus. That's where the maximum function disturbance occurs if damage happens. So networks from there to dorsolateral frontal area and prefrontal areas are disturbed. So where is this problem of repetition? Why Viresh, repetition is important?
For connection between Broca's area and Wernicke's area.
Mhm. Broca's and Wernicke's area repetition. Okay. So what will happen? Where is it disturbed? Where is it not disturbed? Conduction aphasia. Okay.
Conduct
Where is it preserved?
in cortical transcortical
Repetition is preserved in transcortical what? Transcortical. How many transcortical aphasias are there?
repetition. There are mainly three transcortical aphasia, like transcortical sensory, transcortical motor, and mixed variant also.
So it is preserved in transcortical sensory and motor both.
Yes.
Is affected in Broca's and Wernicke's. So repetition is a very important test to start with. Then you can differentiate. If it is preserved, then you are having, if there is spontaneous speech output is reduced, which comprehension is preserved, repetition is affected, writing, reading is affected, Broca's.
Yes.
Right? So language disturbance is a very important dimension. What are semantics and what is syntax?
Uh,
What is the main disturbance in Broca's area?
uh, in Broca's area, mainly Broca's area, mainly syntax is more impaired than the
What do you mean
semantics.
by syntax?
Syntax mainly these are close end words mainly used for the grammatical and connecting the words in the sentence.
Connecting words. So the speech becomes telegraphic,
Mm.
Yes, sir.
agrammatism. Then what are semantics? Semantics are facts. They
Semantics
can
are
only know, they say few words which are facts with no connection words. That is brokers.
yes.
Okay, that's nice. So language, say examination is very important. All of you should have kits for language in exam. For visual comprehension, auditory comprehension, repetition, simple repetition, complex repetition, sentence forming. The aphasia kit for DM exam is slightly more elaborate than the MD exam. So you'll have to refer and make a kit for you or the dementia. Okay, next.
Uh, on tab, mainly is attention is their impairment. So the tab result may be not
Yeah, but you should not do it only, no? If
yes,
only if MMSC is more than 24.
yes.
So importance of MMSC, you showed MMSC, you didn't tell. What is that MMSC you showed?
No, hardly not even 10, no? According to you.
11.
So it is grossly abnormal.
No,
Yes.
yeah, 11.
Abnormal MMSC, so you don't
So
have
then
to.
you can't do an FAB, no? At 11 MMSC.
Yes.
You did all these tests, huh?
Yes. But there's only 4 out of 18.
Anyway,
That
good.
is to be expected. I mean,
Yes.
No surprise in this. Next.
Um, uh, in temporal lobe examination, registration and registration normal, but recall after 5 words, recall he cannot recall any single word, and with there is no any improvement with the cues. So recent memory and episodic memory is impaired. Semantic, which is a remote like birthplace, army postings, these are intact. Procedural memory also intact.
You tell me, how do you differentiate right temporal defect from left temporal defect?
Right temporal from
What are the
left temporal.
manifestations of right temporal lobe affliction as compared to left temporal, and how will you test?
left temporal mainly associated. There is a association with Wernicke's area, so aphasia.
Left temporal. This Wernicke's area is supramarginal gyrus, right? That's posterior aspect, no? So only one area, but what type of memory disturbance you come across in left temporal lobe? How do you test verbal memory?
Left temporal mainly verbal impairment and right temporal visual memory
So how will you
impairment.
test visual memory? Have you tested in this case?
Visual memory, we show the some objects
But did you
and
test
then
here in this case?
not, sir.
How do you say verbal memory? How do you test?
Verbal memories, we give the 5 words,
Hmm.
and then he register, repeat, again repeat, and then after 5 minutes
See,
recall.
5 words at what interval and which 5 words? Suppose
Mainly
I say Monday, Tuesday, Wednesday,
no,
Thursday, Friday. Is it allowed?
no, non-related,
Then
non-related
say
to
the
each
whole
other.
thing, na? Ki they should not be related. And what is the interval between the words that you tell?
Deliberate, one word per second.
1 per second.
1
So
per second. Correct.
you have read race auditory verbal learning test.
Yes.
Race auditory verbal learning test.
Auditory verbal.
Okay. And Benton's visual memory test.
Benton. Yes.
So how will you, so you have to show no visual memory, you have to demonstrate, verbal memory you have to demonstrate. Okay. Anterograde learning you have to demonstrate. Whether there is anterograde learning. What are the tests for anterograde learning? How the individual learns. One is this. How will you demonstrate an individual has anterograde learning defect or not? See, some things you have to be familiar with to do fastly in exam.
Yes.
Antrograde, anybody? Have you heard paired associate learning test? This race auditive verbal learning test is also antrograde learning, new learning ability, correct, but you have to prove it. So, hook pen, okay.
Yes. So, yes.
So give a list of 10 words. You said 5. You give 4 repetitions, one after other. After every presentation, he has to give some answers, how many he remembers. Progressively, if he goes on remembering more and more, that is antegrade learning is preserved.
Mm.
Okay. So similarly, you have to do paired associate learning test for antegrade learning in real bedside. Right, next. What is this book pen? Somebody can explain. What do you mean by that? How will you do this? You can unmute and tell. We may not know all the tests. You must have been taught by some other faculty. What is this book pen test? Paid associate learning. Okay. Okay. That we are aware. Next. Hmm. Right. Parietal lobe.
Parietal lobe, he in this page Necker's cube, he not able to draw that Necker tubes also, and also overlapping the pentagon.
Hmm.
And clock drawing, I asked him to about clock drawing 10, 20. Then he draws like this only one to draw,
Where is
not
where is his clock?
no, there is no clock.
You haven't shown what is his attempt.
Here.
Okay. This one. Acha, acha. That's
This
his
one.
clock. Okay. Right. So
Also,
next. Occipital.
uh, on occipital, matching is possible. He can come incomplete the letter test with goal in figure test also normal. He can differentiate between that real and mainly that picture where there are eggs and hen, and uh, uh, so he
David,
can
right.
yes.
What is Bellnet syndrome?
Sorry,
What are the core features?
sir.
Bellnet syndrome. BALINT.
BL, optic ataxia, oculomotor apraxia, and simultagnosia.
Have you tested? How will you
I
test for simultaneously?
That is a picture of forest and
Hmm.
the tree.
Hmm.
Actually, he did not understand what I am asking to him. And
Okay.
also, there is one picture of the cookie tape picture also. He
Hmm.
cannot understand what to tell about that picture.
How will you test for ocular ataxia? How will you test for ocular apraxia? Cookie thief picture? Somebody said yes, that's correct. How will you test? Suppose if you ask him to look straight at your thumb and ask him to rotate slowly the head to the right or left, the eyes get glued to the
Thumb.
thumb only. There is a delay, right?
Yes.
And suppose you ask him to identify the hand movements in the visual field, which he should be able to. No, he should not. You say in his ask him to look straight, and you make hand movements here and there. He has to point out where the hand is moving.
Hmm.
You're not able to do that. Okay, so these are ocular ataxia and apraxia tests. Finger, target, object, optic ataxia. Correct. Next. So occipital lobe not tested completely.
Yes.
You have to No, you have to keep 2 or 3 tests under your sleeves for all the lobes, which you should be able to tell.
Yes.
Next.
So functions of cranial
All cranial nerves.
or the normals, but there is a non-nystagmus, but saccades are slower. And on anti-saccade examination, it was impaired.
What about pursuit eye movements?
Mm.
What about divergent, convergent eye movements? So what are the conjugate eye movements? What are the conjugate eye movements? And they are affected in which neurodegenerative disorder classically?
Hello.
Yes.
Yes, sir.
PSP. Yes. Duction movement. So convergent divergent, these eye movements are disturbed in PSP, but they can overcome by what maneuver?
VOR.
Yes, oculocephalic reflex. That's correct. You should say fast,
Mm.
quickly.
Yeah.
Right. Next.
But rest of the cranial nerves are normal.
The point
Motor.
to note is every very important is eye movements in neurodegenerative disorder and fundus. Right?
Yes.
Fundus means there should be primary optic atrophy, or
Mm.
anything abnormal you have to mention. Retinitis pigmentosa, there's other things you have to see. Motor system.
Motor nutrition normal. There is no resting. On tone of left upper limb, there is a rigidity than the right upper limb. I notice. Power was a normal reflex. All DTRs +1, and the plantars. Both plantars are the downgoing like this. Sensory was normal. No any tingling, numbness, or any sensory impairment.
What type of sensory disturbance you should
Tingling.
remember here?
You can't say tingling numbness here, no? That is
What type
a
of sensory
symptom.
disturbance?
Mainly
Can't say.
cortical sensory.
You have to mention that.
Yeah.
What are the cortical senses which you have tested?
Graph
Did you test for
stereognosis,
stereognosis, graphesthesia, 2 point?
graphesthesia,
Have you
2-point
tested?
discrimination,
Have you
and
tested?
only stereognosis and graphesthesia.
Have you tested?
Yes,
But you didn't write. Unless you write, how do we know?
yes.
But his attention span is poor, no? Did he understand what you are asking him to do?
I have given a key in hand after closing his eyes, so he noticed that it's key.
Right.
Okay, right.
No cerebellar signs also, and there was no any involuntary movements.
Okay.
But gait was mainly there is difficulty in initiating gait, and gait is a short step gait out there.
The Parkinsonian gait.
Likely Parkinsonian.
Okay.
So, I think
So
some
anything extra you added after examination? Turning stand steps he
ah,
gave in the history. Yeah, somebody.
only tab is very low, but it's mainly due to attention.
Mhm.
In I think.
Anything new you added after examination than what you discussed at the end of history?
No, sir. No significant.
Same thing you have confirmed on examination. Okay, final diagnosis.
With visual hallucination, episodic memory, some dysexecutive function, behavioral impairment, visuospatial impairment, and the seeing apraxia. Mainly same differentials, like dementia with Lewy body.
How will you differentiate from Parkinson's disease with dementia in this case?
Because in Parkinson's dementia, there are the firstly Parkinson's features, and then dementia features. In dementia, Lewy bodies are the dementia symptoms are earlier than the Parkinson's. So
Time
only
course. What is the time
five
course of
5 years,
dementia in Parkinson's?
5 years, sir.
Okay. Rule of 1 year. What is the rule of 1 year?
Not 1 year.
If dementia develops in the first year of Parkinsonian features or dementia begins, then it is Lewy body disease.
Lewy body. Correct.
Okay.
Yes.
Very nice. Anything else you did? Investigations?
Uh, Investigation we do MRI and uh, only PET scan.
You
Okay.
did. What are the
Yes.
reports?
But MRI generalized given atrophy
Hmm.
and
And
PET.
PET you didn't do. It may not differentiate. See, all these things will same, no? For the dopamine deficiency will be there. You will not be able to differentiate with the FDG PET except essential tremor and PD. The rest all okay. But MIBG scan, autonomic nervous system testing, you
Mm-hmm.
can do.
Yes.
So how will you treat? See, some measures are always recommended to improve the quality of life, even though you know that there is no treatment. But these people are not going to die immediately.
Yes.
Okay, so you have to give some preventive rehabilitative measures.
Hmm.
Dr. Sant, anything else or shall we close?
No, that's fine, sir. I think we
Huh?
covered all.
We have covered all, no? Almost one and a half, 1 hour, 15 minutes we discussed. Any questions from anybody?
Uh, yeah,
Sir.
it was lovely discussion I was hearing.
Oh, good. Thank you, sir.
Questions. Yeah, it was lovely.
Yeah.
Yeah. And of course, they are using what they are required to be done for
Hmm.
symptomatic management to make life comfortable for the family and for the patient.
Yeah.
And that should be the, so what was given to him? He is having agitated behavior, he is having incontinence. So what advices you will give to the family?
Uh, Firstly, I will explain the natural course of disease.
Yes.
Right.
Uh,
See, any medicine can help him in controlling the violent behavior and agitation or nocturnal hallucination that you have mentioned.
yes.
Any
Atypical, somebody has written also.
Can you give him Serenase?
Yeah,
No, sir, because may have neuroleptic hypersensitivity, so his Parkinsonian worsens more.
Mm.
okay, so which one you will use out of them?
Mainly
Which is
atypical like
having
quetiapine,
yeah, exactly.
risperidone.
The low doses of quetiapine could be a better
Risperidone.
option and safer option because it doesn't have EPS features. And is he having sleep disturbances also at night? So that will also a bit of sedation at night. So low doses quetiapine would be one of the options. Is there any role of the other medicine for reversing? Which category of dementia you have leveled him now? Mild, moderate, severe.
Moderate.
Moderate. He is already incontinent. He is virtually dependent for all the activity.
Yes.
So this is
How
what
much was the MMSE?
11.
11 or 10 you said yourself.
No, sir, it's severe.
Hmm.
So at what is the cutoff for moderate to severe?
Uh, Less moderate, mainly 11 to 20, and less than 10 is a severe.
Okay. So the other medicine, do they have any role? Donepezil, memantine, or they have found to? See, already the hut is burnt, so calling a fire brigade is not much point.
Yes.
So explaining the progressive nature, the disabling condition, and how to provide the long-term care for the health, hygiene, patient hygiene, preventing the decubital eye or behavior,
Closing falls is
injury,
immobile.
fall. These are the areas of concern.
Yes.
And somebody may probe you on this question, that what advice really you will give to the patient. Okay, you have made this diagnosis. You have done your scientific thing. Okay, it is not Lewy body, or it is Lewy body because of hallucination. It is frontotemporal, or no, it is Alzheimer. These are more for our academic discussion. You will be definitely be grilled on that. And the localization, that's the academic exercise we will do. But ultimately, what advice you are giving to him?
Mainly,
ABC.
these are irreversible diseases with no cure. So the natural history and adjustment with similar complaints and mainly
Anyway, I was hearing your
spirit.
your history presentation was good. And Dr. Sankar Gorthi, I admire the way you have questioned all the low function and quiz the student. It was lovely. Good.
Thank you,
I
sir. Thank you.
tried revising my low function. After a long time, I'm hearing this discussion. Good. Lovely. Thank you, Dr.
Rahul, anything?
Yeah, one question to you, Dr. Gorthi, from my end.
Yeah.
Two things. Number one, we are doing more of MOCA than MMSC in
Yeah.
most of our patients. So, our standard of care is usually MOCA than MMSC. But
Mm.
yes, most of the examiners would love to do MMSC most often. But we know that MOCA probably is better than MMSC. So that's one thing. What's your opinion for this? And second is, no, it is the standard that these students are doing this lobe testing. You look at frontal, you look at parietal, you look at occipital. But then it's probably a good idea to go as per the domain wise, because we know that many domains are multilobar, and in most of the diseases probably it's a domain that is involved. So it's a good idea to do domain wise, or it's a good idea to do lobe wise? That's another question from mine.
So I think by definition, we'll have to go by domain wise. That's very important for us. Now it's a network based
Yes, we know that.
physiology. So that's why it is domain based. And
Yeah.
MMSC plus clock drawing will meet most of the requirements. We don't
Okay.
have to do MOCA because clock drawing will address the executive control function dysfunction.
Yes.
So that's the only thing that is lacking in MMSC, which is very quick to finish. You can
Okay.
master it very easily. Don't have to have any paper with you.
Yeah.
So MOCA is good, no doubt about it. If you can do it, nothing like it. If you don't have it, just memorize MMSC and do a clock drawing.
Yeah, probably MOCA takes about 5 minutes, probably more than MMSC.
But you have to have a paper with you, something.
Yes,
Here,
yes.
MMSC,
We have to
don't
have the
have to do
paper.
anything.
But they are
Yeah.
doing every day, so they are
Yeah.
doing practically every day. They are doing one MOCA at least,
That's correct. They are
what's
doing here, but when they practice, I don't know how much they do it.
right. That's right. Right.
Good.
Okay. So I
Thank
think
you.
it's a good idea to do domain wise presentation than lobe wise.
That's
Rahul,
good.
I agree with you.
No.
Yeah.
So start with probably just MMSC. Just look at attention and then go as per domain. And at the end, maybe you can say that in my this thing at the end, probably these are the various parts in different lobes which are involved.
In the present day, it is a network physiology. So we should move away from lobe function.
Yeah, but most of the examiners still love this
They
lobe
love
this
it.
thing way. Yeah.
Good, Hemant. Good night.
Yes,
Then
sir.
anything else?
Yeah.
Nice.
Right.
Thank you.
Thank you.
Thank you.
Okay, good night.
Good
Good night,
Take care.
Piyush.
Thank you.
Yes.
Good night.
Thank you
sir.
very much. Thank you.
Well done, Viraj. Well